Welcome to the Liver Lounge, your go-to podcast for the latest updates in hepatology, featuring discussions with the world's leading experts.
So thank you so much for joining us today, Professor. So basically, given your expertise in the field of NAFLD as well as a recent paper in BMJ, exploring the different dietary interventions as well as also why diet is so important in NAFLD, could you just bring us through how is diet important in NAFLD?
Yeah, thank you for inviting me to this chat. And the diet is crucial in NAFLD because it could be the cause of the disease, but also the solution of this disease. This is the title of our last talk last week, and I'm deeply convinced about that. When you have your clinical practice or even in the lab, you demonstrate that people eating a high-fat diet, a diet rich in saturated fatty acid, in ultra-processed food, in sugar and sweetened added beverage, you are promoting several changes in your liver that end in the metabolic associated steatotic liver disease that could progress to steatohepatitis and also to fibrosis, cirrhosis, and many other complications. This is the main reason that by which we start doing an intervention in 2015, 8 years ago, and we demonstrate that in people doing a hypocaloric diet, losing 10% of the body weight, we can solve the disease in more than 90% of the patients with steatohepatitis. And steatosis disappears in 100% of the patients if you are losing 10% of your body weight. And fibrosis stage could regress at least one stage from 3 to 4, from 3 to 2, from 2 to 1 or 1 to 0, in more than 80%. If you take into account all this data and put inside a pill, you have the best therapy for any disease. And the main concern when we finished this study with Professor Romero-Gómez was that just 10% of the population reached 10% body weight lost. Okay, this is the main limitation. But for sure, if we are treating MAFLD, the new name of this disease, the metabolic associated steatotic liver disease, if we treat with diet and we promote weight loss, we can improve the liver a lot. But we need to consider a couple of things that they are not completely overlapping. One of them is it's very important to weight loss, but it's also very important to eat the high quality calories. For example, some oils like olive oil, very rich in monounsaturated fatty acid, like the oleic acid. In this case, you can eat a large amount of this fat, but promote a beneficial effect on the liver. Everything you are eating, you don't need to avoid calories. The key point is to eat as better as possible. Another very important study done 12 years ago was comparing what is happening in the liver of people with overweight that eat 1 extra liter every day of milk versus Coke. If you think you are having a standard diet, but you are eating an extra liter. If you are eating an extra liter for 6 months of milk, the fat in the liver not change in these 6 months. But you are eating every day a liter of Coke, your fat in the liver increased by 140%. In spite of the amount of carrying 1 liter of Coke is a little less than 1 liter of milk. That means the key point is not the calorie, it's the quality of the nutrient, the quality of the diet. If we move a little more forward, we need to keep in mind that beyond the diet, we need to add the physical activity. It's completely different the effect of a diet, an hypocaloric diet, in a patient with sedentarism versus an active people. If you are doing fitness, if you are doing some exercise, you don't need to be a marathonian, right, to reach a perfect fitness state, but you need to be just a people avoiding sedentarism. If you are avoiding sedentarism, you can improve your liver in spite you are not doing the diet that you require for weight loss. Okay, this is the key point. I'm trying to clarify just weight loss is the best manner to improve your liver, but if you are eating very well with a high quality diet, you can improve your liver in spite of not losing weight, but also you can improve your liver doing physical activity.
Okay, and I think the fundamental difference in that is also that high fructose diet is a major cause of
high fructose, ultra-processed food, and high saturated fat. This is the three enemies of the liver.
Right, but changing these dietary habits can be challenging. So how do we approach such situations? Because
it's to address this is a very challenging because you can modify your lifestyle, but it's not just because you need to modify, you change your environment, your friends, your habit, and it's a very difficult. This is the key point by which we need to look for the best change in the diet that could allow you to be as closer as possible to your standard diet and just improving the key point that could allow you to improve your liver. This is the geometry of the nutrition by which you need to keep in mind, because initially we are putting a label in the different nutrients. If you are eating fat, very bad. If you are eating carbs, very bad. If you are eating protein, it's okay. But you cannot eat just protein. You need to eat protein plus carb plus fat. Ideally, we need to think what is the best diet for a patient, and we need to try to modulate according this taste, these habits. For example, Mediterranean diet is a very nice diet. It's very close. It's widely used in Europe and mainly in the Mediterranean basin. And you can eat many completely different foods and in an interesting proportion. If you are avoiding these three enemies, ultra processed food plus saturated fat and fructose, high fructose food, you can have a very rich in vegetable, fruit, with a lot of fish, a lot of fruit and meals rich in different fatty acids that could be beneficial for our health, like omega-3 or oleic acid, monounsaturated or polyunsaturated fatty acids. This is the main reason by which we need to work trying to convince our patient to have a diet as closer as possible with the current diet, eliminating the enemies and trying to look for the friends that could allow the patient to improve the liver.
Right. But when we also know that health disparities is unfortunately a true thing, and accessibility to food for patients with of the lower income may be a little bit more challenging, and often in the States especially, the food that they access are generally the ultra processed food and thereby affected by NASH. So this health disparity is a real thing, and would it be better if public efforts is focused on the food aspect rather than the disease aspect? Maybe that would improve health faster.
How can we address that? For sure, we need to keep in mind that we need the help of everyone, all the stakeholders involved in the diet of the people around the world. For sure, taking account incomes and many other factors that we can discuss later. And on the other side, we need to look for what could be the best manner for the patient for the people to reach this type of change in the diet. This is, for example, the opportunity for the intermittent fasting. when you are doing intermittent fasting, you just need hours. You need to look at time, and you are eating for 8 hours, but you have no restriction. You can eat everything, and you are not eating for 16 hours, for example, every day, 5 days per week. At the end of the day, you are reducing food, and the size of your stomach is reducing. And at the end of the day, you can improve your metabolism, and you can promote improvement in the liver. For sure, if you are doing a very strict diet, like a keto diet, and you are avoiding carbohydrate, as you know, many carbs in the food that we are eating, in the most tasteful, in the most friendly situation, and if you are removing carbs and eating just a keto diet, for sure you can promote very important effect on the liver. We need to demonstrate that. But we need just to design the tool that the patient requires to have the skill they need to be adhering with the best ideal diet that should be as close as possible to the diet they are doing every day. And for sure, to address everything is a very, very difficult challenge that we need to address working all together, for sure.
So what are the kind of diets that are available for patients with NASH? I mean, we all know the Mediterranean diet is, from the gut paper, has shown one of the best outcomes. But aside from that, what other kind of dietary interventions can they employ to reduce their burden of NASH?
We need to keep in mind that we are selling the soul of the Mediterranean diet. You can find the traditional Chinese diet is Mediterranean. The Blue Zone diet in Japan is Mediterranean. The quinoa diet in Peru and Chile, they are Mediterranean, because they are a diet with a large amount of vegetable, of fruits, or fish, with a very low amount of meat, and no ultra-processed food, no any saturated fat, or high fructose, industrial fructose food. And if you take the backbone of the Mediterranean diet, you can look at and you can find in Africa, in Asia, in America, and in Europe. And the idea is that people need to be educated that the things we are eating are very important. We need to avoid alcohol consumption, for sure. We need to avoid these enemies of the liver, like the saturated fat and the ultra-processed food and the fructose. And after that, we need to increase the rest of the food. And in this case, we can go ahead and improve, for sure, the health of the liver.
Okay. So, with the recent new drugs that's been coming out in NASH, and as well as also procedures endoscopically, do you think that diet still forms the major aspect to the treatment of NASH, and then all these are adjuncts, like Medicaid, like semaglutide and other drugs are more like adjunct therapy? My point is, diet is the cause and the solution of the disease. And for me, every patient with NAFLD need to undergo an intervention with diet and physical activity. For 3 to 6 months, we can check if the patient could respond to a lifestyle intervention. If the patient is responder, everything is okay. This patient is suffering from a liver disease strongly related to the diet and the physical activity, and we can control and manage this disease doing that. But if the patient is non-responder, if we cannot promote weight loss, if we cannot promote liver improvement using different non-invasive tests, we need to move forward doing different approach. One of them is, could we try to reach more weight loss using
drugs, for example, anti-obesity drugs, semaglutide could promote weight loss, tirzepatide could promote very important percentage of weight loss, and for sure we can use a technique, for example, metabolic endoscopy or bariatric endoscopy or bariatric surgery. I think we need to try to best educate our patient to convince them that if they modify lifestyle could change completely the prognosis of the disease, and they could reach at least 10% of the body weight loss. If they are not reaching that, we can discuss with them the possibility of use all these intervention to promote weight loss. Okay. In the other part is when we are using drug able to improve the liver, because at this time we are using drugs that could promote weight loss, but other drugs like resmetirom or fructifermin, pegozafermin, agonist FGF21, that has been released the data from the phase 2. They are very promising drugs that they are not promoting a very impressive percentage of body weight loss. That means we need to keep in mind that we have all this intervention and to promote how can we improve the liver health using these drugs, and perhaps we need to improve how are we stratifying, enriching the clinical trials to give the drug to the patient that will more benefit of this drug. For example, it not makes sense to use an anti-obesity drug in a lean patient. If you have a patient with muscle and lean, with body mass index lower than 25, you need to focus on the improvement of the liver and perhaps on the physical activity, but not on the diet. But in obese people, you need to implement the change in the lifestyle. If not, you can use some endoscopic approach, or you can use drugs to treat the obesity, or for sure combining with drugs focusing on the liver metabolism and the liver health.
Right. And so I think the next question that I'll kind of like to ask is, are those dietary interventions also suitable for patients with like lean NAFLD, like the lean variant of the NAFLD, rather than the obese and overweight?
Sorry, I'm not listening. I don't know. It's raining here in Seville.
Oh, okay.
No, okay, much better.
Yeah.
Could you repeat?
Yep. So I think that leads on to the next question that I have would be, would NAFLD, like lean NAFLD, also benefit from all the Mediterranean diet and intermittent fasting as would the obese patients do, or is it more of the only suitable for patients with like obesity?
The key point from my point of view, the key point in the lean NAS is that the patient needs to be stratified as truly a lean patient, or it could suffer from visceral obesity and apparently a not overweight patient. For example, you can have 23 kilos per meter squared as body mass index. That means you are a lean patient, but you can have 40% of visceral fat, and you have so large amount of fat, you are not a lean. You are an obese people with a normal body mass index. In this case, for sure, we need to treat the patient in the same manner. Okay, as an obese, and we are implementing lifestyle intervention, activity, physical activity, etc. If our patient is not suffering truly from obesity and no visceral obesity, no any problem on this way, the idea is try to take advantage of the physical activity. Perhaps if we are improving the muscle, avoiding sarcopenia, avoiding losing muscle mass, we can improve the management of this patient, and we can improve the health of the liver. In patients with lean NASH, true lean NASH, the key point is to use physical activity as the pillar for the treatment, and in the second part is to use drugs that could improve the metabolism in the liver, but that could decrease the novel lipogenesis, that could improve the beta oxidation of the fatty acid, that could improve insulin resistance, that could improve the different mechanistic pathway that promote muscle weight, but not strictly related with obesity and overweight.
Okay. That's actually a very interesting way of thinking about lean NAFLD. I've never thought about using, in patients with lean NAFLD, if we just take the BMI approach, then I always thought that the pathogenesis might be slightly different compared to those with the non-lean NAFLD, where maybe a PNPI3 variant is the major cause of the liver dysfunction, and hence they might benefit more from targeted therapies. But I think you're right, even the visceral obesity in lean NAFLD is something to think about. Or we shouldn't just look at the BMI as a major indicator of whether they should be treated with lifestyle interventions. I think the major takeaway is, I think lifestyle interventions still form the fundamental aspect for NAFLD or MASLD management.
This is a big opportunity for the personalized medicine that will stratify current patients with MASLD, in which we can detect exactly what is happening in a lean NASH versus an obese people. And we can be surprised because some mechanisms could be shared and could appear in both diseases, but many others could be completely different. For example, microbiome. The gut-liver axis is a very complex topic in which we are trying to look for some light, but it's very difficult. It's very complex. It depends on the genetic of the patient, on the metagenomic, the genetics of the bacteria and the archaeas and the virus, etc., but also depend on the metabolome, how is the metabolism and what are the metabolites this patient is producing, and we need precision medicine to better understand exactly what is happening in a patient with MASLD, and in this patient trying to better stratify. And my idea is we need to use a puzzle. You are putting the different pieces, and if you need 3 pieces, you need 3 therapies targeting this piece. But if you have a perfect insulin resistance, not make sense that you are using an insulin sensitizer. If you are your body weight is 25 kilo per meter square, not make sense to use anti-obesity drugs. No, and this is my idea. We need to decide which are the key aspects in the pathophysiology. For sure, insulin resistance, the lipid metabolism, mainly the novel lipogenesis and the beta oxidation, but also the ammonia production, the microbiome, the immune disorders, and putting all together, which I'm trying to have a level for each patient, and you are deficient in these 3 targets, and you are overexpressed these 2 targets, and the key point is to put on the cocktail, and you are giving the best therapy for each patient. But it's a long, long way to reach any conclusion that we can demonstrate scientifically, for sure. Okay.
Thank you so much, Prof. I think it was an excellent conversation to have on dietary approach. Thanks for sharing the viewers on this aspect of NAFLD.
We have come to the end of the episode. Thank you for joining us, and stay tuned for more captivating discussions.